I didn't see kind of brand new data coming out that really kind of surprised me. I thought, oh, that's a real advance. But what I did see was continuing follow-up on the studies we've already had. So we've seen, for instance, the 5-year follow-up that Susan O'Brien presented on Ibrutinib. Now, that's really important because the publications that we have really have very limited follow-up. And we're starting to see mechanisms of resistance. Jennifer Woyach gave a very nice talk highlighting the work that they've been doing on the emergence of the molecular mechanisms of resistance to the drug and looking back and tracking. They've now got an approved assay that they're running on patients with Ibrutinib, and they can track when patients start to become resistant. We also saw, of course, here a lot of data on combinations of novel agents together, which is important if we're going to start thinking about, well, if we start to see resistance to Ibrutinib coming in with an additional agent, might make sense before patients have clinical relapse. And then, of course, Kathy Wu's group has had a number of publications and presentations here looking at this clonal evolution picture at very deep molecular level, the subclones of CLL that are arising and how that might be altered by some of the therapy. Big question a lot of us have is that this complex karyotype of CLL that emerges, that is associated with very poor prognosis and poor outcome to agents like Ibrutinib and potentially also to venetoclax, are they driven by changes that occur from chemotherapy? And as we move from an era of chemotherapy into novel agents only, might we prevent those bad subclones from arising? So a lot of work beginning to emerge in that setting. A lot of work also on new and second generation compounds coming out, looking at alterations in the safety data, looking at the tolerability and the safety. But for me, the kind of interesting stuff is going to be related to the combinations. Are we able to drive people into MRD negativity? We also saw some interesting data, 2 presentations on lenalidomide maintenance in CLL. Now, there's never been a role for maintenance therapy established in CLL, but 2 presentations at this meeting demonstrated improvement in progression-free survival, but not overall survival, on using a maintenance regimen with a low-dose lenalidomide approach. So it's an interesting concept, and whether or not it's lenalidomide that turns out to be the agent that's going to be used in maintenance, but it does kind of add additional information to us to think that a maintenance approach, particularly for those poorer risk patients, may be indeed a way forward.